Welcome to Lesson 7 of our DSM-5-TR series. Today, we're exploring a fascinating and important group of neurodevelopmental conditions known as tic disorders. These conditions often begin in childhood and are characterized by sudden, rapid, recurrent, non-rhythmic movements or vocalizations called tics. Understanding tic disorders is essential not only for clinical practice, but also for recognizing the complex ways in which neurological, psychological, and environmental factors interact. In this lesson, we'll examine the different types of tic disorders recognized by the DSM-5-TR, including Tourette's disorder, persistent chronic motor or vocal tic disorder, provisional tic disorder, and other or unspecified tic disorders. We'll go through diagnostic criteria, associated features, prevalence, development and course, risk factors, differential diagnosis, comorbidities, and more. Let's begin. Understanding tics. Before diving into specific disorders, it's important to define what we mean by a tic. A tic is a sudden, rapid, recurrent, non-rhythmic motor movement or vocalization. Tics can range from simple, such as blinking, sniffing, or throat clearing, to complex, such as coordinated sequences of movements or uttering phrases. They often occur in bouts and may change in type, frequency, or severity over time. A unique feature of tics is that many individuals experience a premonitory urge, a sensory sensation or inattention that builds up before the tic occurs, followed by relief afterward. Tics are not completely involuntary. They are often described as semi-voluntary or suppressible, meaning the individual can sometimes delay or suppress them, though usually with increasing discomfort. With this foundation in mind, let's turn to the primary tic disorders described in DSM-5-TR. Tourette's disorder, F95-2. Tourette's disorder, often referred to simply as Tourette syndrome, is the most well-known tic disorder. It is defined by the presence of both multiple motor tics and one or more vocal tics that have been present at some time during the course of the illness, though not necessarily simultaneously. Diagnostic criteria. According to DSM-5-TR, the criteria are as follows. A. Both multiple motor tics and one or more vocal tics have been present at some time during the illness, although not necessarily concurrently. B. The tics may wax and wane in frequency, but have persisted for more than 1 year since the first tic onset. C. Onset is before age 18. D. The disturbance is not attributable to the physiological effects of a substance, e.g., cocaine, or another medical condition, e.g., Huntington's disease, post-viral encephalitis. Examples of motor tics include blinking, grimacing, shoulder shrugging, or jerking limbs. Vocal tics can include sniffing, grunting, throat clearing, or uttering words or phrases. Persistent chronic motor or vocal tic disorder, F95.1. The next category is persistent chronic motor or vocal tic disorder. This condition is similar to Tourette's disorder, but differs in one crucial way. Only motor tics or only vocal tics are present, not both. Diagnostic criteria. A. Single or multiple motor tics or vocal tics have been present during the illness, but not both motor and vocal. B. The tics may wax and wane in frequency, but have persisted for more than 1 year since the first tic onset. C. Onset is before age 18. D. The disturbance is not attributable to the physiological effects of a substance or another medical condition. E. Criteria for Tourette's disorder have never been met. For example, a child with only eye blinking and head jerking tics for more than a year would meet criteria for persistent motor tic disorder, while someone with only throat clearing and grunting would meet criteria for persistent vocal tic disorder. Provisional tic disorder, F95.0. Provisional tic disorder is diagnosed when tics are present but have not yet lasted a full year. It is often a diagnosis made early in the course of a tic disorder and can later evolve into one of the chronic forms. Diagnostic criteria. A. Single or multiple motor and or vocal tics are present. B. The tics have been present for less than 1 year, since first tick onset. C. Onset is before age 18. D. The disturbance is not attributable to the physiological effects of a substance or another medical condition. E. Criteria for Tourette's disorder or persistent tic disorder have never been met. Many children with provisional tic disorder experience spontaneous remission, while others go on to develop a chronic tic disorder or Tourette's disorder. Other specified and unspecified tic disorders. F95.8, F95.9. When an individual exhibits tic symptoms that cause significant impairment but do not meet full criteria for any of the above conditions, the diagnosis may be other specified tic disorder, F95.8, or unspecified tic disorder, F95.9. These categories are used in situations where tics are present, but the clinician either specifies the reason the presentation does not meet criteria for the other specified category, or chooses not to specify for the unspecified category. Associated features supporting diagnosis. Tic disorders often occur alongside other neurodevelopmental or psychiatric conditions. The most common comorbidities are ADHD and obsessive-compulsive disorder, OCD. Anxiety disorders, depressive disorders, and autism spectrum disorder are also seen with higher frequency. Many individuals with tic disorders experience premonitory urges before tics and describe relief after performing the tic. Tics can be exacerbated by stress, anxiety, fatigue, or excitement, and they often decrease when the person is focused or asleep. Social difficulties and stigma are common. Children with prominent tics may face teasing or bullying, and adults may struggle with social interactions or employment challenges due to visible or audible tics. Prevalence. Tourette's disorder affects approximately 0.3% to 0.8% of children, with motor tics typically appearing between ages 4 and 6 and vocal tics between ages 7 and 10. Persistent motor or vocal tic disorder is slightly more common, with prevalence estimates ranging from 1% to 2%. Provisional tic disorder is even more frequent, affecting up to 3% to 4% of school-aged children. Males are affected more often than females, with ratios of about 3.1 to 4:1. Males also tend to have earlier onset and more severe symptoms. Development and course tic disorders almost always begin in childhood, with the first tics often appearing between ages 4 and 6. Motor tics usually precede vocal tics, and the most severe symptoms typically occur between ages 10 and 12. For many individuals, symptoms decrease significantly during adolescence and early adulthood. However, in a minority, tics persist into adulthood, sometimes with fluctuating severity. The course of tic disorders is often waxing and waning. Periods of increased frequency or intensity alternate with periods of relative remission. Stress, excitement, or fatigue can exacerbate symptoms, while focused activity may reduce them. Premonitory urges and the ability to suppress tics often develop with age. Children may not initially be aware of these sensations, but adolescents and adults often describe a rising inner tension relieved only by performing the tic. Risk and prognostic factors. Genetic factors play a significant role in tic disorders. Heritability estimates are high, and family studies show increased risk among first-degree relatives. Environmental influences, such as prenatal maternal smoking, low birth weight, or perinatal complications, may also increase risk. Psychosocial stress, infections, and autoimmune processes have been investigated as potential triggers or modifiers, though findings are mixed. Importantly, comorbid conditions like ADHD and OCD can influence severity, persistence, and functional impact. Culture-related diagnostic issues. Cultural context plays an important role in diagnosis. Cultural beliefs about tics can affect help-seeking behavior, stigma, and diagnosis. In some cultures, tics may be misunderstood as deliberate behaviors or spiritual phenomena, delaying clinical attention. Sex-related diagnostic issues. Males are diagnosed with tic disorders more frequently than females, and they often present with more severe symptoms. Females, however, may be more likely to have comorbid obsessive-compulsive symptoms, which can affect the clinical presentation. Suicide risk. Although tics themselves are not directly linked to suicide, comorbid conditions such as depression, anxiety, and OCD increase the risk. Persistent social difficulties, bullying, and low self-esteem can also contribute to suicidal thoughts or behaviors. Comprehensive care should always include screening for mood and anxiety symptoms. Functional consequences. The impact of tic disorders extends beyond the tics themselves. Children may experience academic difficulties due to distraction, stigma, or social rejection. Adults may face employment challenges or discrimination. In some cases, severe motor tics can lead to physical pain or injury. Despite these challenges, many individuals adapt well and lead fulfilling lives, especially with supportive interventions, psychoeducation, and, when appropriate, behavioral or pharmacological treatment. Differential diagnosis. Distinguishing tic disorders from other movement disorders is crucial. Stereotypic movement disorder involves more rhythmic, patterned, and prolonged movements, and typically begins before age 3. Myoclonus and chorea are less suppressible and not preceded by premonitory urges. Seizure activity must also be ruled out, as must functional neurological symptom disorder, where movements may mimic tics but have different characteristics. Attention deficit hyperactivity disorder, obsessive compulsive disorder, and autism spectrum disorder may involve repetitive behaviors but differ in their phenomenology and underlying mechanisms. Comorbidity. Comorbidity is the rule rather than the exception. ADHD is present in up to 60% of individuals with Tourette's disorder and OCD in about 30% to 50%. Anxiety, depression, and disruptive behavior disorders are also common. These comorbidities often have a greater impact on functioning and quality of life than the tics themselves and must be addressed in treatment planning. Summary. In summary, tic disorders are neurodevelopmental conditions characterized by sudden, rapid, recurrent motor movements or vocalizations. They typically begin in childhood and follow a waxing and waning course. The DSM-5-TR recognizes several types. Tourette's disorder, with both motor and vocal tics for more than a year. Persistent, chronic motor or vocal tic disorder, with one type of tic persisting for over a year. Provisional tic disorder, where tics last less than a year. And other or unspecified tic disorders, used when criteria are not fully met, but impairment is significant. Genetic and environmental factors contribute to these disorders, and comorbid conditions are common and clinically significant. Although tic disorders can lead to functional impairment and social difficulties, many individuals experience improvement over time, and effective behavioral and pharmacological treatments are available. Thank you for joining Lesson 7 of our DSM-5-TR series. In our next lesson, we'll continue exploring neurodevelopmental conditions and deepen our understanding of how they affect behavior, learning, and daily functioning.